So again, welcome friends and everyone. Thanks for joining us. I am pleased again to have the honor of having Anne Fonfa from the Annie Appleseed Project. And we're going to talk about something that's very important, has to do a lot with the advocate work that think about the effects on the patient. And we need to have patient-centered oncology treatment. And sometimes that's not always the case. So Anne's been a great proponent of that. And we're going to look today at how to really deal with some of the harms. Are there any natural ways we can deal with that? What needs to change to incorporate? So tell us what you've been doing. You've been a great champion for this, looking at the harms and how we can integrate some natural things to help patients deal with the bad side effects of treatment.
Yes, thank
So
you. It's really interesting to talk about, Judy, because it's something that it happened for me. I became unable, well, I was unable when I was diagnosed originally to do conventional treatment. So I didn't do chemo or radiation for breast cancer. I didn't take hormones, but I was in a support group, and being outside of the system, so to speak, I could see everybody was getting ill, more ill. One of the weird things about breast cancer in general is you don't feel sick mostly. You find a lump or you find a change, and then you get treatment and you're really sick. And people lost their color, they became like grayed down, lose your appetite, nausea, vomiting, all that kind of stuff. And I was an observer because it wasn't happening to me. So the things that I was doing was building my system up, juicing and being physically active and trying to eat organic and things like that. And the people that I was talking to in the group were very interested in what I was doing. So I began to talk about it. But also at the same time, one of my closest friends became an acupuncturist. And in order to support her new business, I became her patient. I had no idea what she could do. But in 3 months, my menstrual cramps stopped. So I was very, very impressed with that because, I didn't have the worst cramps in the universe, but it wasn't great. And here she had taken it away, and I didn't even know that was happening. It just happened within a 3-month period. So those two things combined, watching people suffering and being helped from what I consider, and I call acupuncture like it comes to you sideways. It doesn't do anything like you think it's going to do, but it does stuff. So those things combined for me to see that there might be ways to deal with those kinds of issues. And I had mentioned to you earlier that I was thinking about pain and suffering because there was a guy, I finally managed to look him up, and I'm going to tell you who it was because I thought it was super interesting. His name was Andrew von Eschenbach, and he was at the time he became the president-elect of the American Cancer Society, and then he started to head up the National Cancer Institute. So his theme was to reduce the pain and suffering, and this all happened in 2003. Okay, so in 2003, his theme was we're going to reduce the pain and suffering for people with cancer by 2015. Well, what did they do to do that? And that would be basically nothing. There was no real change. They just went along, we're going to find new drugs, we're going to better treatment, which is always the goal, of course, better treatment, more effective treatment with less patient resistance. Why do we resist drugs? Because they're harming as well as helping. So our bodies are rejecting the treatment over time because you destroyed a lot of good things as well as the bad. So his goal, completely amorphous, and at the time I resented it tremendously because I didn't think there was any plan behind it. And in fact, there wasn't. Between 2003 and 2015, there was no reduction in pain and suffering, but there have been some changes and some movement in that direction. Several things happened. PCORI, which you may know, which is patient-centered research outcomes, and there's a whole system now from the government, and they give grants. But I went to their first meeting, and like so many research programs, grant reviews, it's so complicated, and nobody really got to the issue. First thing they had to do was figure out how to define all this stuff. So they're still working their way through it. So to me, it was very confusing, and there was nothing that looked at actually pain and suffering or anything like that. It was more remote. And the other thing that happened was, and this happened, I want to say like 2016, 17, something like that, ASCO, the American Society for Clinical Oncology, ran a survivor symposium. And that was done in San Francisco, and several of my board members live in California. So 3 of us were at this meeting, and they were talking about the fact that they're noticing that people are being harmed a lot from treatment. And as we know, what's the harm? The number one harm the heart, right?
Mhm.
I mean, you're in danger from chemo because anthracycline therapy is very damaging, and also from radiation. So it was very exciting to be at a meeting where they were actually saying, hey, we've noticed that there's some harms. Just the introductory meeting. And the next year, we exhibited and we brought our handouts. So my group, AnnieAppleseedProject.org, has created a handout about simple natural things that might help reduce various problems from treatment. So we brought that, and oncologists had not seen anything like that. It's not talked about. As you know, oncology is about what the pharma industry is offering
Right. They
only.
don't want to deviate from the protocol, standard protocol.
Right.
Right.
And it's
Yeah.
understandable, because if you step out of line, you're,
Mhm.
problematic. But it's not so patient friendly. So this second year was research began to be developed. And the third time they did it, they say the third time's the charm. They came up with a solution. But their solution to me and to our people like me was ludicrous. They said, we have established a division of cardio oncology. So what is that going to do? That's going to follow you for the rest of your life when your heart is damaged. So ask me where the reduction of pain and suffering came with
Mhm.
that. Yeah, nothing. So that was odd. And I was a critic, but that's my thing, critic. But I thought,
Good critic.
the idea would be to step in between the damage and the problem. So what they do now, as you probably know, and you probably had these tests, but since I didn't do conventional treatment, I didn't have any of these, but they measure your heart to see how strong it is. And almost everybody, his heart's pretty okay. And the ones that are not, they recognize, and they can give them a different chemo, which is interesting because I was diagnosed long enough ago that they had different chemo. They had what they call CMF, which I no longer remember exactly what it stands for, but it was instead of anthracycline treatment. And by the way, the anthracycline offered what's called a 3% benefit. It's 3%, it's
Right.
not much. I was at the meeting in 2000 when they had a consensus conference to discuss whether it should replace CMF, and that they chose to replace it. Myself and several other advocates said, why? It's not enough of a value, and there's this big harm to your heart.
Mhm.
But that was ignored. So, okay, so now you have a division where they're going to follow you for the rest of your life after your heart is damaged. Well, that's not a good idea. So on our handout, simple stuff, herbs, maybe
Mhm.
acupuncture, physical activity, a variety of things that may reduce the risk. And to me, it's worth a try, because once you have that damage, it's very rare that it heals itself. I mean, I wish it were the real answer that, wow, you could just get better, but you can't necessarily. And we don't know why some people have a really bad reaction, and others don't. Nobody's really looked into that. But one of the things that was discovered was when Herceptin came out, which was a very useful drug for people with HER2 positive breast cancer and now other cancers, combined with anthracycline drugs, it was very heart damaging. And they noticed that.
Yeah, they
But
do the
it didn't
MUGA test.
change.
They do a MUGA test. I forget what that stands for as well, but I think it's
Yeah,
to do with the
yeah.
heart muscles, how the heart muscles are functioning. Yeah.
Yeah, it has something to do with the left ejection fraction, whatever that is. And it's something about the way your heart handles blood flow, and it can be greatly reduced after the treatment.
Mhm.
So that's damaging, and you get weak, loss of breath, and so on. But
My
the fact
sister-in-law
of,
had that happen to her during receiving the Herceptin. She had an episode.
yeah,
So I know, yeah, it was scary. It was very scary. So I'm
and I
sorry to
think, yeah,
interrupt.
no,
Yeah.
no,
Yeah.
but the issue is we have to prevent it, find ways to prevent it. I mean, in my mind, the pharma should aim to find a drug that might prevent it. But, I do have an issue with pharma drugs in general, because every single drug helps, but it also harms. We hear the commercials. Everybody knows
I
now
know.
that you could ignore it, but you can hear it. I mean, yesterday I was listening to something that was really, well, because I don't suffer from it, I thought it was a
Mhm.
minor problem compared to what you could develop with the
But
treatment.
everybody's always running through fields and having picnics after they take the
That's
drug.
right. Right, especially if they're allergic, they're going through the forest and having a great
Right,
old
I
time,
know, but they're
with
happy,
allergies. But hey,
I
yeah.
know. Those people did not take this drug.
Yeah, and it shows you the complexity of the human body. I'm sure when the first idea was just target this issue and it'll be great, but it hasn't worked that way, and it still doesn't work that way. When you do one thing it reverberates in the body and it does a lot of things. And it's kind of shocking how many things it can do in comparison to what the aim was. And again, it's not enough of a focus, because harming people and then following them to make sure what are you doing? I mean, did it get worse over time? Maybe, probably. Following them didn't change that.
Have you come
Now,
across
maybe
any information, excuse me again, I'm sorry to interrupt, any information about the connection between chemotherapy and then developing leukemia later on as well? Another side of
well,
it or not?
yeah, I mean, clearly that's an issue because a subset of people with breast cancer and others develop leukemia. Leukemia is a semi-common side effect, so to speak, an adverse effect, a harm from a lot of drugs. You know, you hear that quite often in those advertisements. You know, it reduces your immune system and you got to be careful of infection and you might develop leukemia, which
Or
is
lymphoma.
serious.
Yeah, or
Or,
lymphoma.
well, yeah, or lymphoma.
Right.
And that's quite serious. There's no question. And it's not totally treatable. And the treatment is a big thing. I mean, you have to go through transplant and all that stuff. Stem cell. It's tricky. Yeah, it's tricky. So there's possibility that PCORI may develop into something, you know, patient-centered outcome research. It, may move into something where they really can prevent harms. That would be great. But you know, the biggest pain and suffering is nausea and vomiting and neuropathy. So on our handout, there are a lot of good ideas for that. And my chemical sensitivity, which was my big issue prior to the breast cancer diagnosis, was well handled with the smell of peppermint oil. And it turns out that works along with ginger for nausea and may control vomiting as well. So, and then diarrhea, there's simple thing, activated charcoal, clove tea, although personally I hate the taste of clove, but if you don't hate the taste, it could be very useful, you know, but simple things, because the Western herb tradition, you know, is one herb at a time. I'm a fan, as people know, of traditional Chinese medicine, which is a whole bunch of herbs. And I have that cooking on my stove right now. It's like 30 different herbs. And the good part about that, from my view, is the harms are prevented right up front. So, for example, if you take an herb that makes you dizzy, there's another herb that stops you from getting dizzy. And if you're going to get a headache, you have an herb that stops a headache, and so on. So it's well balanced. That's the Chinese tradition. In Western medicine, they give you an herb which can interact and work with the issue, like hawthorn berry, which is good for the heart, or dietary supplement CoQ10, which may in fact prevent the harms. Worth a try. It's been studied.
Yeah, CoQ10 also, if you take a statin drug, you really should take the CoQ10 also, it depletes that. But the thing, don't you think though, I run into this a lot with people where they won't do anything without asking their oncologist. And many times the oncologist answer is, well, I don't know what that's going to do. So I really don't want you to do it. So how do you overcome that? It's very frustrating to me to say, well, we have evidence-based in the way that we've studied survivors, but we don't have any concrete evidence to say it'll work for you, but it won't harm you. But why are oncologists? I know the answer, but I want to get your opinion. I know the answer, but yeah, give me your opinion. Why are they so negative about all of this stuff? They're getting better. Some of them are getting better. Yeah. Yeah. What do you
I think, you know, it's an interesting question, because everyone says, make sure you consult your doctor before you do something, and they're protecting themselves from a lawsuit or problem. But the truth is, the doctors say no, and sometimes they don't say, I don't know what it is, therefore no, they just say no. And that's shorthand for, I really don't know about it. But, you know, because it's a whole other system to have to look into. And let's face it, our docs are busy and they don't have time. I mean, somebody once said that they have to read, a GP, general practitioner, family doctor, has to read 16 papers a day to keep up with the journal. So imagine in oncology. So they don't do it. That's one thing. Second thing is, pharma doesn't promote or support that kind of thing. And that's a problem. They don't want to get out of line, because, you know, there's a lot of issues that can arise. Hospital privileges, payment for, you know, whatever. It's tricky. But the other part of that that's really a painful situation is that if they don't know about it, they're not willing to necessarily. I mean, some are. Did they speak to my acupuncturist about what that could do? Not necessarily. If that combination of Western medicine and holistic approaches or Eastern approaches would be great. It would benefit the patient because why not? That's what integrative oncology is. It's the things that you can also do that may make it better for you and could enhance the efficacy of the drug and your own health and well-being, which is very, very important. It took forever for physical activity to be recognized as meaningful and helpful, and nutrition, that's still
Right.
I was on a discussion on Facebook the other day where people were talking about dumb things they got served for food in the hospital, and I've mentioned this before. I discovered after being in the hospital for a couple of days that they had salad, and I said, "Oh, that's great, I'll have the salad." And you know what they gave me? A bowl of iceberg lettuce just by itself. So, I mean, that's crazy. So we have a lot to overcome. There's a lot of issues, and the doctors, they don't have time to know about nutrition. They're not taught in medical school. And I'm sympathetic. They don't have time. They're so busy, and the insurance company is crushing them from this end. And, it's just not easy for them. So shorthand version is no, don't do that. Meaning I don't really know about it, so I can't say. But lots and lots of people are taking their own health into their own hands because kind of have to. And there's some people we know get through it better than others. And if you ask them, it turns out they were doing integrative medicine.
Well, you and I talked about in a previous video that we did that in an ideal world, each oncology practice would have someone on site, whether it be a nurse practitioner or even a medical student, that would be in charge of researching the latest things and then reporting back to the team. And that would be someone that would be their job. But the other thing is, other survivors that I videoed, they don't monitor the harms. They don't ask the questions. They don't go in there and say, how is your quality of life? What side effects are you experiencing? They just say, well, your chart looks great. Your chart looks great. But as I told you, one of the survivors I interviewed, she said, but I feel like crap. She said, my quality of life is so bad that we've got to do something. And that's what they did. They actually ratcheted back medicine, and she wasn't cancer free, but she was stable and had a much improved quality of life. So I think a message we need to get out there is that you don't always have to be on the top dose of the drug. Be honest with your oncologist and say, can't live a normal life or have some quality of life, then they need to know about it, but they don't ask usually.
Yeah, that's a very sad thing. And also that, you're suggesting someone be on staff. That's an insurance reimbursement issue. Currently, insurance companies do not reimburse, generally speaking. There are a few that pay for acupuncture treatments and so on, but generally they don't reimburse for a staff person to know integrative oncology. Should be, but it's not. So that's, insurance, that's a big issue because they're not covering things that matter. And people are afraid to talk to their doctors because they feel like either the doctor will be mad, which is your life, but you don't want your doctor to be mad at you, which is terrible. And also the nurses generally are more attentive to that area and are the ones who tend to ask more. And so people will tell them, but yeah, they don't ask. And if you ask, you'll find out. And that's very important. It doesn't happen. Related to this that I've thought about a lot, I thought about it yesterday when I saw a study. It was a retrospective study. So retrospective studies are not considered fabulous evidence, but I don't understand why. And I say that because when you do a retrospective, you can see who survived, how long they survived, etc. And in a prospective study, you're guessing, and especially if these days, as is very common, the trials are not focused on what they call OS, which is overall survival, actual survival. They're mostly focused on disease-free years or time, not years usually, months. But retrospective, the treatment they had and how it came out. Their life and death, which to me is very important. But the pharmaceutical industry does control that, and they teach everybody the highest level is the prospective study, and that's so drilled in that everyone thinks there's no other thing. And what's the lowest? The lowest is patient reports, how patients feel. That should be changing because now clinical trials are supposed to have a questionnaire or a conversation or something that says to people in the trial, how was it? But this, again, is one of my earliest objections. I went to FDA meetings in the 90s when I was first diagnosed, and the presentation of a new drug would be there were no unexpected toxicities and everybody was happy, nothing unexpected. And I said, well, but the unexpected, the expected toxicities, they're terrible. I mean, neuropathy, the vomiting, the nausea, the heart, it's, it's going to happen. So it's okay. Doesn't make it okay to know it. And that hasn't changed. That mindset is still the same. There were no unexpected. And so knowing that people are going to take a new drug and an old drug in general, or a placebo, although they swear over and over there's no placebo trials, but there are. And so both arms are suffering for whatever combination of things. So there should be complementary medicine offered to everybody in a clinical trial. So there won't be that expected toxicity, which are perfectly okay because it wasn't unexpected. And I want to say another thing about that, which is if it's unexpected, how do you know it happened?
Right.
No one's looking for it. How do you know?
I wonder if we could get a grant to make a questionnaire for patients that are just getting regular chemo to say, what dose are you getting? What harms did you experience? And put that in some kind of a database if anybody would pay any attention to that.
Yeah, it's an interesting idea. People minority or ethnic minority as well don't get into trials. They don't, they're not invited. They're not part of the community that's being involved and so on. So that immediately means that, let's say I have diabetes, which I don't, but if I go to my doctor and I want to have this new drug, doc, I just saw this sounded so good. Could I take it? Doc says, well, I don't really know, but yeah, sure, why not? And it's an experiment of what they call an N of one. You're the only person in this group because there is no group for somebody with diabetes taking this drug. How crazy is that? It just doesn't make sense, and it's inappropriate because those people, who knows what their harms are going to have been, that their pain and suffering, we don't even know because that's not tracked. Community, it's phase 4, which doesn't happen very often in a clinical trial. Additionally, the drug Xeloda. A lot of people took Xeloda. When it was approved at 2,500 twice a day. 2,500, I guess, milligrams. So it became obvious over time to some doctors who called themselves in the know that the dose was very high and people were suffering tremendous neuropathy and problems from the drug. So a couple of docs went on talking tours and they came to share nonprofit in New York, the cancer nonprofit in New York. And one of the doctors, I think it was Vogel from Florida, and he said, well, doctors in the know, we're cutting the dose. And I said, when you say that, I hear, what are the doctors not in the know doing? Right. They're given 2,500 twice a day because FDA approved it. So how did FDA approve it? The same reason. The healthiest people were in the trial, and apparently they didn't complain, or they weren't heard, who knows. So FDA approved it at a very high level. So to get, nowadays, almost everybody does know that you shouldn't get that level. But that's a classic example. It may be that all the drugs are at too high a level, as you suggested, that some people may need a lower dose. But, docs hesitant because there's no backup and they're not protected. And if something goes wrong, they could be sued and so on, which is a terrible system, but it's so backward. That's a real issue because that really happened. Xeloda was approved at 2,500. People are doing 2,000 or 1,800, even less sometimes. And, it's a shock because there's no system for a patient to be able to go to FDA and say, that was too high. Can you change it? And a couple of us went to it, Musa Mayer and myself from Sharon, New York. We had a conversation with an FDA person and she said, well, the sponsor has to resubmit a trial at the lower dose and then we'll consider it. So there was no way the sponsor's not going to do another $10 million trial or 25 million or whatever. Not going to happen. So that drug's out in the world at the wrong dose. And who knows, some people may still be getting the recommended dose, which is too high. Shocking. Terrible.
I was just reading a book by a survivor who interviews survivors, and she had colon cancer in particular, and she was suffering such sores in her mouth and her feet, sores on the bottom of her feet. And finally, she said to the doctor, this is after 6 months, she said, I don't think that I can take anymore. And he said, well, I think that that's probably the right way to do it. And so the original protocol was 9 months. And since then, she got 6 months, and thank goodness she's still fine 4 years later. But now the new protocol is 6 months. In some ways, they don't figure it out until they figure it out. Nobody's looking at it until it works for somebody that it happened by accident.
The surgeon who did my 2 lumpectomies and 2 mastectomies, not my first lumpectomy, wrote an article recently discussing the fact that there'll probably be a reduction of surgery coming up. Surgery has been reduced over time. It used to be a full axillary node dissection, dramatic mastectomy. Over time, that's been lessened. They've actually been studying that to do less, which is quite interesting. In the world of chemotherapy, you point to something where it became less. And that's very, very important, because I think, I had a friend who was treated in the 80s with breast cancer, and she had a year of chemotherapy. Nobody has a year anymore. It's different now. And people were overtreated to the max. And the same with radiation treatment. They were treated, overtreated, heavily treated. That's gone down. So we're moving, but it's snail pace. It's very, very slow. I mean, I say this about, I was in sales of business presentations, and we had a computer system when no one had computers, and people were creating business presentations. They were fabulous. The software changed every month. Every month. In the medical field, we're lucky if every 25 years there's a change. Usually it's more like 40. I mean, right now we're talking about liquid biopsy, circulating tumor cells. So that was presented in the San Antonio Breast Cancer Symposium in 1998. That was the first meeting I ever attended, and I saw a whole bunch of posters out of Germany. And now, 2022, it's a big discussion. It's not even fully accepted to this day. And, the medical community, the whole system is just so slow.
I had an appointment with my oncologist yesterday, and it's a new, actually, it's a breast surgeon. They're new. I finally got somebody in Florida that I'm comfortable with. But I told her I had lobular in situ, and she said, now if it's hormone receptor positive, we don't excise the area. If it's in situ lobular, we just treat with hormonal therapy. And I was blown away by that, because my sister-in-law had it 4 years ago at Dana-Farber, and she had to have surgery. I haven't had a chance to look that up yet of when that was changed, but that's incredible that they know enough now, that because surgery is not only psychologically damaging, but to me, it's the less we cut, slash, and burn, the better. So it seems like they're sort of moving in the right direction.
But slowly. Yeah, but it is. There's no question. When I was diagnosed January 1993. Had an aunt, not a blood relative, whose mother had died of breast cancer, and she had atypical hyperplasia, the treatment for which was a double mastectomy, bilateral mastectomy, at a time when I had a lumpectomy for having actual invasive cancer. So that was really upside down. True, she never developed breast cancer, and maybe that stopped it, but maybe not. It was just a thing that was automatically done. And DCIS, ductal carcinoma in situ, was hysteria, and now not even it's considered stage 0. It's still overtreated, in my opinion. And and I have friends who've been diagnosed with that, and they have a mastectomy, and then they want to give them radiation. And I'm saying, why? Because in my opinion, based on some science, if you treat somebody now and they develop a recurrence or a new occurrence, you've already treated them, and now you can't give them that treatment. It's the same with giving people chemo just in case, which a lot of doctors recommend. I think you're okay, but just in case, we'll give you chemo. Well, in my opinion, that just in case is not a grand idea, because you might need it further down the line if you are in fact at risk, which nobody knows because we haven't figured that out. Although I shouldn't say that. We now have the oncotype and the mammoprint, and we do have some clue. But using treatment just in case, especially if you have a good outcome with those tests, that's crazy. But you might need it later on, and in any case, you probably didn't need it right now.
In my early diagnosis, of course, I didn't know anything about anything fixed. I was new to the oncotype test. The oncotype test had just been accepted. Matter of fact, big question whether my insurance company is going to pay for it. But I just said to my oncologist, well, shouldn't I have chemo anyway? Isn't more treatment better than not? And she said no. And she did explain it quite nicely to me. And she said, you don't need it now. And if we need it later, we won't have it if we give it to you now. And I never thought of that. And we all know that cancer cells get smarter. So if a treatment, is used, and then the cancer cell learns to go, to avoid dying or the apoptosis, then yeah, it made sense to me, but I never thought of it that way. You know, we always think in America, more is better, right?
Oh, yeah. And
Yeah.
also, it's kind of covered in the news, and everyone thinks automatically, oh, you should have chemo because you have cancer. And they don't know anything about it, or, and not enough about it for sure. And just in case, not great. And I'm glad your doctor explained it. That's brilliant. I mean, that's a really important thing. And it confirms what I
Mhm.
said as well. And I think it matters because it's not like there's no harms, it's not like, okay, and everyone experiences a little bit differently. Some
Mhm.
people very difficult, some people
Mhm.
not. And of course, people tell me they were doing integrative medicine when they did well. They developed lifestyle changes, which we know matter. When I say lifestyle changes, it actually has a science. It's called epigenetics. And
Right,
we know
right.
that what we do in our life or not do impacts our genes. Can't inherit it. Your children can't get better because your genes got better, but our personal life can be better if we do some exercise and if we healthy and so on. That does make a difference. And that's
I don't think the general
really good
public
work.
realizes you can turn your genes on and off, those oncogenes. I don't think, it wasn't until I went to Project Lead that I realized, oh my gosh, you mean I can turn off a cancer gene? I have that power.
Yeah.
I never really heard about it.
I want to throw in, we were talking about Andrew von Eschenbach, and I said that he had discussed reducing pain and suffering between 2003 and 2015. Absolutely nothing was done about that. But also the critique that I saw in Wikipedia, it says under his leadership, the FDA, he became an FDA director after the NCI, and said they were criticized for being too risk averse when it came to considering life-saving treatment for desperate and dying patients. But that's been an issue all along because you have to find that space between approving too early and not approving in time. And it's very difficult space because different patient groups, and sometimes they're what they call those plastic groups or, faux groups sponsored by pharma, move it along too fast. But again, as I mentioned, the standards for approval have lowered, in my opinion, not just my opinion, but in my opinion as well. And overall survival used to be the thing. And several trials were needed and so on. That's not really happening so much. The problem I see is life-saving is not happening. It's not happening. I mean, I've complained about this forever from the beginning, that every drug that gets approved has like a 2 to 3 month advantage. And
Mhm.
even that's not survival advantage, that's disease-free advantage, but you're still in treatment. So I'm not sure what the gain is because as we talked about, the patients, they're unhappy. They're having a lot of issues. There's many issues. We've only discussed a few. There are people who lose their hearing. There are people who go blind. There are people who lose their voice. I mean, there are serious things that can happen, and we don't know ahead of time who those people are, and that's really creepy. But the fact is that a drug, in order to be approved, hits the same mark over and over again, different drugs, same mark. That's the one. We'll forward that one. We'll move that ahead. We'll put money into it. We'll put research effort. Where's the 6 month drug? Where's the 2 year drug? It's very rare to have that happen. Very rare. I mean, I can only think of a couple of instances over all these years, and I've been around in the cancer world for 29 years, and I can't think of more than 2 or 3 that achieved any value.
Well, don't you think there should be more of an honest discussion with the patient to say, this drug is only shown to have extend your life by 3 months? Do you, I mean, I know everyone is different, so there is a chance that person would react differently, but shouldn't it be the patient who makes that decision to say, I'm going to have good quality of life and I may live longer, but if I'm going to be miserable and I'm only going to live for 3 months, I don't see that happening, that honest discussion happening unless you talk to other survivors.
Well, that's right. And other people, I mean, I just spoke to someone whose mother had made a decision not to do treatment because she had advanced, she was diagnosed at, what they call de novo at diagnosis stage 4. And they were clever enough to say, well, what do you see happening as a result of treatment? Doctor said, well, you might live 2 years, but if you don't do treatment, you'll die in 3 months. But she said her mother got a full 3 years or 4 years, whatever it was, it was a better choice. And she didn't suffer during treatment. So that's a complex issue. And it's something, and I'm reminded of the story I've told a bunch of times. My uncle had lung cancer and it was untreated, and it went to his brain, metastatic. And he had a big brain tumor. They couldn't operate, and he was in Mount Sinai Hospital in New York. I didn't know a single thing about cancer, but I was in charge. I'm the family go-to. So doctors, he didn't want to talk to the doctors, so they talked to me. Two doctors said, if we don't give him chemo and radiation, he is going to die in 3 months. And I was like, oh my God, we can't let that happen. So I said, yeah,
Right.
do it, because I had the usual uneducated opinion that chemo radiation would be fabulous.
Right.
So he had it. It was torture, of course, and he died in 3 weeks. And I said to the doctor, what happened? What happened? Doc said, we didn't promise anything, kind of, it's on you. You misheard what they said. So I always say to people, ask the doctor, what is the outcome they're expecting from this treatment? We're expecting we'll be cured. It'll all be over. Everything will be great. And they're saying, we're going to treat you. Why? Somebody's stage 4 and they're treating you, or, some of the cancers that are less than treatable or less treatable. You really have to think hard about it. Do you want to have your last year of life be a lot of pain and suffering? Is that worth it when there's no possibility through that treatment, and they can tell you going in, you're not going to survive longer, you're not going to be happier, it's not going to work better. And that's a real frustration, because everybody wants something that'll help them. Yeah. Years ago, when I was, early on in my understanding of all this, people used to say to me, my doctor told me to go home and wrap up my, life and make my will and all that. And I'd say to people, what your doctor said was, in the conventional world, we don't have anything else to do. You might want to try some alternatives. With no guarantee. I mean, I can't say, but I do know. I know people who have benefited from doing alternative medicine, but something's alternative up until the time that it's recognized by mainstream and brought on board. And that's happened before. Things that were absolutely poo-pooed, like circulating tumor cells, liquid biopsy, now becoming a thing. But not just that. There are other things, and dendritic cell therapy, hypothermia, hyperbaric, although we don't use it broadly, any of these things broadly enough. We should, but we don't. But they should be clear, but they don't communicate clearly. I mean, we need to be able to say, and that's a hard thing to do, doc, what's the outcome you're expecting? Now, I will say this, I'm dealing with follicular lymphoma since 2019, and my doc always greets me with, you're not in remission. And I say, okay, but we didn't have to start there,
Right.
But I mean, I want truth, but I don't want it, I want it a little more gently, but I know I'm not in remission. I know that this is not going to end with a complete success, but I don't care about that, because I have always been all about right now. Right now, I'm happy, I'm healthy, a good appetite, my energy's great, life is wonderful. That's my life. I don't, I'm not dealing with how's the end going to be. Everybody dies. That's the end for everybody.
Get out of this world.
Nobody gets out alive, period.
Right.
And so we have to focus on that too. And it's a combination. The balance is, how much treatment versus how I want to be living my life. And, I want to be living my life without pain and suffering due to treatment. But I've always had that view, and I still have that view, and it's working out for me. Has worked out, and it's still working.
But also, one that is not really pertaining to this topic, but I had a really interesting discussion with a therapist at the Cleveland Clinic, and I just said to her, why do you think we're having so much cancer? Like, she's a very balanced person. She eats well and she decompresses, she shuts off her cell phone. And she said, because toxic in, toxic out, we're getting such toxic messages from the universe, from our daily lives, that I just limit my television watching. I limit the news. I don't listen to, and I didn't really think about that. Going back to when we grew up, we had Walter Cronkite, and he reported the news, and the news was the news. It was, today the statistic happened. It wasn't, in my opinion, so-and-so is an idiot. I mean, it's like we're getting so much negative energy from our environment, and I never really thought about that. That would be an interesting thing to research.
Yeah. So it's interesting in a lot of ways, because we didn't used to know about every car accident, every murder, every robbery, now we hear every day, the news pounds it. Like they say, if it bleeds, it leads, and they lead with horrendous stuff.
Right.
It's not all bad. But we don't know it. But the other part is, people who are eating healthy or exercising, and they say to me, how could I have gotten cancer? I live such a healthy life. I say, well, your environment, and I don't mean toxic news, although that could be included, but chemicals in the air,
chemicals, yeah.
pollution, it's everywhere and it's unavoidable. It's
Mhm.
unavoidable. Even if
Right.
you eat organic, you're getting the neighbor's field blew over your organic stuff.
Right.
Oh, I had a horror story the other day. I was at the green market and I saw in a bunch of fruit that I had bought the week before as organic, I saw one of them still had a label on it that clearly said for something, something, something. But you know, numbers are, if it starts with 4, it's not organic. If it starts with 3, it's probably GMO. If it starts with 9, it's
Yeah.
organic fruit or
Right.
vegetable. So I saw that sticker and I got so sick, I walked away. I should have taken a picture so that I could have complained, but I didn't because I was just horrified and I got upset, you know, it just crushed me that I've been working with this group and buying their fruits and vegetables for a few years. The first year that I saw them, I was suspicious because their blueberries were so big, the strawberries were so big, and in general, organic fruit and vegetables are not so big unless you grow it yourself. So I was suspicious. I didn't buy anything from them the first year. And then I had a long talk with the guy. I'm a cancer patient. I run a nonprofit. I care about people. And he assured me over and over, and here I saw 2 or 3 or 4 years later, whatever it is, that was a lie. And it was very, very upsetting, very upsetting. And I didn't do the right thing. I should have taken a photo, but I didn't. So now I'm just complaining into space with no evidence. And I
Wow.
do like evidence. So.
Mm-hmm.
But yeah, we have a toxic world and it's worse because of the news. I think the news loves to, you know, they're like my doc starting out with everything's not good. You know, they start out with everything's not good. And look at this, you know, this horror story, that horror. It's not necessary, but we hear it. The only good thing in my mind that you know about war deeply shows people war is hell. What are we doing? What's the point? But not enough people are getting that message, you know, even though it's brought back every single day. It's crazy. You're sending your kids over. What are they doing? They're killing random people. Anyway, different story.
Right.
But
Right.
yeah,
Yeah.
it's
It's
a
funny
shame.
though, when I was living in England from 93 to 97, with the exception of the royal family uh, gossip, you turn the news on, so and so, you know, presented a goat at the 4-H fair today, and it was like all I was thinking about this the other day because I remember thinking to myself, why were we so relaxed we were living over there? You know, I always tell people it was a great place to bring up kids because it was safe and it was. And then I was thinking, like, I was pretty relaxed too. Why was I relaxed? Go to the grocery store and I would buy, nothing was plastic. It was in crates and paper bags and it went bad
Mm,
in 3 days if you didn't eat it, and anyway, different topic, and I'm sure it's
yeah,
changed
that's good
over
though.
there now. I'm sure it's changed. Yeah.
Yeah, no, but I think you're right. Toxic environment, and it's, you know, it's a thing here. That's why people think crime is such a big deal when in fact it's not any worse than it's ever been. It's actually better,
Mhm.
lower. But we're freaking out, and it's very frustrating. It's the chemicals, the environment, the stress. It's a problem, and it definitely, you know, stress is a factor in cancer, no question.
They say for sure,
We
yeah.
know it.
Yeah.
So you have to learn to handle it, which is a good thing to do anyway for everybody.
Yeah. So I guess we need to, what's our closing advice? I guess. I don't know if we have advice, but it'd be really, I was thinking of this when I was getting ready for our meeting was we should do something live from San Antonio. We'll have,
Oh,
we'll have
are you
to,
going to be there?
yeah, I'm going to be there. You're going to be there, aren't you? Or you're not sure yet?
No, I can't. I really
No.
can't.
Okay. Okay. Well, I could call you from there.
No,
Yeah.
by the way, for anyone listening, it's free for advocates. It's
Right.
free. You just
Yeah.
have to sign up. And
Yeah.
you can also watch it on the Alamo Breast Cancer Foundation's website
Hmm.
because they're going to be doing their mentoring program in which very famous and important doctors will run down what happened, what they heard that day, and advocates will ask them questions. It's a fabulous part of it.
Right.
And
Right.
I think of San Antonio as a place to meet advocates because to me, the presentations are so mainstream that you hardly ever hear anything about nutrition or exercise or stress reduction. Occasionally, but it's rare, and it's usually like early morning, the last one of the session. But the posters are excellent, and the posters are well worth reviewing because they show what's new, what's upcoming. And you know, there was a couple on medical cannabis, which you don't hear covered in conferences at all, and we
Hmm.
should. But you know, that's another whole issue. I wouldn't mind discussing that as an issue. It's I
Okay.
despise the way that's systemized state by state. It's ridiculous.
Yeah. Let's
But
plan on
yeah, I'd
doing
love
it.
to do San
Yeah.
Antonio with you.
Let's do
So,
something like that.
but
I'm going because we're having a poster for the vaccine. But
great.
while on that same topic, I will tell you when I went to ASCO this year I came back and I was very discouraged because of the mask thing. We've talked about it. I don't want to belabor the point, but I've met so many interesting people and I collected business cards, and it's been a great gift for me because I'm in contact with these people now, and I've had several of them doing videos with me. But it's the people that you meet, and also the networking. To me, sitting and just talking with other advocates and learning what they've been
I agree.
doing, it gives you such hope. Hope is what we really need. Hope is what we're all working hard for. And sometimes we get in our little corners and we don't realize. Every time I go to a convention, it's a great blessing. And
No, I agree. It's wonderful to
yeah.
meet with advocates, and everyone's carved a piece of it for themselves that they want to work on. And that's very important because there's so many issues, many issues. I just want to remind your listeners that we're going to have a conference for Annie
Yes.
Appleseed Project, February 23rd to 25th in West Palm Beach, Florida. The information's up on our website, annieappleseedproject.org. We have a little bit different look on our website, and we'd love anybody to come who's interested in integrative medicine, lifestyle issues, and holistic approaches. Everybody's welcome. We have a scholarship program for people with advanced cancer or unpaid advocates, because y'all deserve a break. So that'd be really fun. And, when I go to the conference, that gives me the opportunity to talk to people about the work we do, which is still pretty unique in the cancer world, pretty unique. But some of the ideas we've had for many, many years have been adopted, and a lot more people are aware of how important lifestyle really is. And, that's great.
Well, that's it. Your conference as well is an opportunity. A lot of the advocates that go to your conference have experience with complementary medicine that they've done themselves, or things they've added to their diet. Again, networking, you can, and your conference is amazing. So I encourage everyone to sign up for it. Go to annieappleseedproject.org. I also have the link on my site, sistersforprevention.com. And again, Anne, great as always talking with you. You always have such interesting things to say. And the next one will be about medical cannabis. Those are the kinds of things that, thanks to people like you, I wouldn't even have thought about doing. So anyway, till next time, thanks so much. And as always, it's such a great honor and pleasure. And everyone, again, go to annieappleseedproject.org and sign up for the conference, and stay tuned for our next video. So
thank you very much. Appreciate
see you later,
it.
honey. Thank you so much. Bye-bye for now.
So as Ann and I discussed, there are helpful supplements you can use to reduce chemo side effects. So ginger can help you manage nausea and vomiting from chemotherapy. The caution is that it may also thin your blood, and so don't take it immediately before surgery. Peppermint has also been found to help with nausea. Zinc can help prevent taste changes, a side effect of radiation, chemotherapy, and some pain medication. Astragalus root might ease the side effects of chemotherapy, such as nausea and vomiting as well. Glutamine could help reduce at least 2 side effects from treatment: peripheral neuropathy, which is a weakness, numbness, or pain in your hands and feet, and especially mouth sores and soreness on the bottoms of your feet, which we know are quite painful. Ginseng in high doses was found in a Mayo Clinic-led study to reduce cancer-related fatigue. And guarana, a natural stimulant found in a plant native to the Amazon basin, has also been found to help with chemotherapy-related fatigue, especially in breast cancer patients. So what about other practices that we spoke about to reduce chemo side effects? Massage therapy. One study of 1,290 cancer patients found that the pain, anxiety, fatigue, and nausea dropped by among half of those who got a massage. Hypnosis therapy. A trained practitioner will put you in a state of deep concentration that helps you focus on things other than your symptoms. It can help to ease anxiety, pain, stress, and even nausea. Guided imagery, I used this so much during my recovery period. You focus on the thing or place that makes you happy. It helps you relax, and one study found it improved the quality of life for women with breast cancer. Acupuncture. There's no sure way to prevent peripheral neuropathy from chemotherapy, but a study published in the European Journal of Cancer in 2018 evaluated the effectiveness of acupuncture in preventing peripheral neuropathy in women with stages 1 to 3 breast cancer receiving weekly paclitaxel. Acupuncture was well tolerated and shown some effectiveness in reducing the incidence of high-grade chemotherapy-induced peripheral neuropathy. Oral cryotherapy. The topical application of ice, known as cryotherapy, is thought to prevent mouth sores in people receiving 5-FU chemotherapy, or fluorouracil. Oral cryopathy involves cooling the mouth with something cold like ice cold water, popsicles, or ice cream. So these are some of the helpful practices you could use to reduce chemo side effects. We hope you will find these of use, and also for other tips on diet and lifestyle changes to help prevent recurrence or help you heal from breast cancer. Please visit my website, www.sisters4prevention.com. Thank you for watching, and have a wonderful day.